to you, Nitin, sir.
Hello, everybody. Welcome to this very, very important webinar by ICS, which the basic topic is essentially going to be very, very important topic of COPD Gold 2025. What is new and what you need to know? That's going to be the real crux of the matter. And I have a wonderful panel to discuss this. But before I introduce the whole idea, let me thank Dr. Sandeep Salvi, the president of ICS, Dr. Amita Neve, the chair ICS, and Dr. Rajadhar, secretary of ICS, to start with. At the same time, let me thank the Lupin team as well as Dr. Aditi for being wonderfully hosting this seminar through and through. And let me have the first slide, if you don't mind, Aditi. Can we go on to the next slide, please? Yeah. And before I invite the very important Dr. Tilaga, let me invite you to NAPCON Pune between 23rd to 26th January 2025, which is being held in JW Marriott. We have 23rd as a dedicated workshop day, and 24, 25, and 26th January will be our conference days. We are having amazing response to this conference, and I hope and I'm sure you will make this one of the most memorable ICS events, one of the most memorable NAPCONs, which will be there to be witnessed by all of us. With that, let me move on to the very, very important talk of the day, which is going to be given by Dr. Tilaga Swami. Can we move on to the next slide, please? Wonderful. And Dr. Tilgavati, she is a head of the department and a senior consultant in respiratory and sleep medicine at Vijaya Group of Hospitals in Chennai. She has been a faculty in national and state conferences, NAPCON, TAPCON, awarded the Inspirer in Pulmonary Medicine in 2013 by ICS. She has remarkable publications on rare lung diseases, tracheal bronchus, alcosis, a case of pulmonary myeloma configured within mesopulmonary aspergillosis, so on and so forth. And wonderful community passion also, in the terms of conducted workshops in many conferences, and member of the National Board of Sleep Medicine Fellowship. So with that, let me introduce Dr. Tilgavati. I'll introduce the rest of the panel later, but she's going to talk to us about what is new in Gold 2025 in the next 20-25 minutes. So, Dr. Tilgavati.
Thank you. Thank you very much for a kind introduction. Let me share my slides first. Are you able to see my slides?
Yes. Yes, ma'am.
Yeah, you're able to hear me?
Yes, ma'am. You need to hide your presenter view, ma'am. Next slide is also visible here.
Okay. Okay, sure. Now is it okay?
Yes, ma'am. Perfect.
Yeah. Okay. Good evening, one and all. Thank you for the overwhelming response of so many people logging in. Shows the enthusiasm to learn and always enlighten. So let me share my knowledge on what I have understood from the new update. I thank the ICS, especially Dr. Rajadhar, Dr. Sandeep Salvi, and Dr. Amita Neni for this wonderful opportunity. I'm really privileged and honored to give this talk today. So I named the topic as Paradigm Shift in COPD Management because from 2023, there is really a shift in the way the Gold document is being published. So let me take you through this new document, what is so important. So the first and foremost is this is how is our capital city today, Delhi. So it's so much of pollution. And I put up this slide just to show that traditionally we used to think that smoking is the cause of COPD. Now we have moved away from this. The first message is 40 to 50% of Indian COPDs are not due to smoking and are due to mostly indoor and outdoor pollutions. So that's the first message. So we are moving away from smoking as the main cause to the other air pollutants and other particulate matters. So about gold, a few words about gold. This is all evidence-based material. There are a group of international experts who meet around twice a year, and then they review. For this document, they have put up some 3,000 publications. They have reviewed a humongous task. I think we should congratulate them on doing such a work so that we are able to manage our patients better. So this is about gold. And a word about clarity is power. This is from the famous book by Noah. So it's a word in a world deluged by irrelevant information, clarity is power. I think I will be able to help you with this. And also you will agree with me that clarity is power by the end of this lecture. So gold, initially the gold document or the gold COPD document used to run through so many chapters, but of late they have reduced it to 5 or 6 chapters. And in this new update, they have taken off the chapter on COVID-19 and they have placed it under comorbids. So it's practically a small, crisp one with lots of references. I think they've added some 164 references to the topic. It's impossible to go through all the references, but from my little knowledge, what I have gone through, what is important, I'm sharing with you. So why are we talking today about this COPD? We know that it is the third major killer or cause of mortality all over the world. And we know that urban areas, it is due to heavy pollution. Rural areas, it's still the biomass fuel and other things. The most important is there are over 500,000 hospitalizations due to COPD. And 1/4 of them are readmitted within 3 days. So this is just to show that smoking is not the predominant one. As we move, lots of countries have all household pollution, ambient particulate matter, occupational exposures, and smoking is becoming less and less. So the next is what contributes to this. There are various risk factors, environmental exposures in a genetically prone patient. What happens is there is damage to the epithelium, and the epithelium damage triggers a lot of reaction, and how the epithelium reacts to the injury and heals is the basic platform on which this COPD signs and symptoms are based. So most often, if your a risk factor continues and the injury continues, this damage is going to keep on going. So this is in a host, susceptible host. If you have the risk factors and all these environmental exposures, then you develop COPD. So this is a reductionist model, I would say, a simplified model of the COPD. And previously, we cannot say, I don't know, this is only for immunologists. We need to know because we are treating all asthma and COPD airway diseases with biologics. So this is just a small reductionist model, I would say. So once the epithelium is injured and environmental triggers, the triggers can be various, which causes the epithelium to damage, and the damaged epithelium results in alarmins being released. The alarmins are TSLP, IL-33, which results in a host of response. It can go to TH1, TH3 type of response, which is predominantly neutrophil, or it can take the TH2 type of response, which is predominantly the eosinophil type of response. So all these various interleukins which are poured and pro-inflammatory mediators which are poured, they are responsible for the final outcome of the COPD patient, causing the damage to the lung, parenchyma, airway, persisting chronic inflammation, and the small airway obliteration, parenchymal destruction. All the findings are all secondary to this various pro-inflammatory mediators. So what happens in all these mediators? There is an imbalance between oxidation and antioxidant. Oxidative stress is there. There is a continued inflammatory process. There is impaired immune regulation, and there is a protease antiprotease imbalance. This is responsible for destruction of the alveoli, destruction of the parenchyma, destruction of small airway disease. And progressively, if the risk factor and the trigger continues, the inflammation goes on to produce metaplasia. So normally cells which don't have mucus glands change to mucus gland metaplasia and keep on pouring secretions to eliminate the particulate matter. And the cycle goes on and on and on, which is responsible for the COPD signs and symptoms. So there is a new concept which they have introduced in the pathogenesis, which is called dysbiosis. So this is just evolving concept. I think it is a fresh approach to pathogenesis. So why is lung microbiome so important in this scenario? So if you see a normal lung, we know that lung is not sterile anymore. We have a lot of organisms there. And if you have a symbiotic, just like how you have a symbiotic bacteria in the gut, the same gut, there is a crosstalk between the gut and the lung, and there are good bacteria in a normal patient in eubiosis. But if your patient has got COPD or asthma, or if your patient has eosinophilic asthma or fibrosis, bronchiectasis, EPF, there are some organisms which are being studied and which is always there in a subclinical level. And in an exacerbation or a viral infection, this becomes predominant. So how does this concept help you in your day-to-day practice? The only thing is, this is a place where we have to watch. I think watch this space. There might be more data, more drugs, more information on this. But for now, I think if there is some role for restoring the gut microbiota in the form of pre, pro, and post probiotics, with the help of probiotics. So there is a concept called, in the 2023 gold is actually a revised document, but the 2024 and 2025 is just an update to that document. So they introduced this etiotypes. So the etiotypes is like, I think all of you are aware of this table because it is there in the 2023 itself. So the only thing what I want to say is they have just labeled genetic factors as COPD-G. It's just an alphabet soup. But the most important here is air pollution, cigarette smoking as C, and pollution as P, and all this. The most important thing what I want you to focus attention on is COPD and asthma. Gold is not encouraging asthma COPD overlap syndrome. They call it as COPD-A. But GINA guidelines still concentrate on ACOS or asthma COPD syndrome. So how does this etiotype help you in your practice? So what treatment implication it has got? Why do they want to give this table? That's because etiology matters. You cannot treat what you don't see. So if suppose you identify that it is alpha-1 antitrypsin deficiency, definitely you have treatment, augmented treatment for that. There are some treatable factors, or you can avoid exposures if you really know the etiology. And by the way, I want to mention that alpha-1 antitrypsin is not rare, but it is rarely looked for. All COPD patients should have, in the ideal scenario, if the country's prevalence is there, you should have done at least one alpha-1 antitrypsin deficiency levels. So this is just for that implication. So moving on to the gold definition of COPD, please read the definition in 3 parts. This helps you to define the newer terms better. So it's a heterogeneous lung condition which has chronic respiratory symptoms, and you have abnormalities of the airway and or alveoli, and then which is persistent, progressive, producing airflow limitation. So there are 3 components to this definition. One is in the form of respiratory symptoms, the other in the form of structural destruction, structure related to the structure of the respiratory system. The other one is in the form of spirometry, impaired function. Why I'm stressing these 3 components is because when I define new terms, this will be so useful when you define pre-COPD, early COPD, and other things. So keep this in mind. So the next one is, we know that normal lung, we achieve as we grow, the lung function peaks at the age of 20 to 25. Then there is a brief plateau, and then there is a physiological decline in lung function, which is very normal. So if this trajectory is so important, because either if you don't achieve the peak, or you have an early decline, or there is an accelerated decline, all this determines your COPD. And if you add risk factors to this, imagine if you have early life disadvantage like premature lung development, you have not achieved the peak, or you have childhood respiratory infections, all this can change this trajectory, and it can pave the way for a severe COPD early on in life. So the importance of early diagnosis is stressed from 2023. We are not going to wait till the lung function becomes bad and then diagnose COPD. That's the idea. That's the early identification of COPD is really needed to shift the treatment paradigm. This is the most important first message from 2023 document, that this is what we should concentrate on. The various events, be it genetic, early life events, infection or other things, can produce a fall in lung function. The trajectory falls, and then there are symptoms, and then the lung function also deteriorates, and before final end organ damage occurs. So the goal is looking for something where if we diagnose COPD very late, by the time there are a lot of symptoms, by the time there are a lot of irreversible changes in the lung, can we do this diagnosis earlier? Can we interrupt the disease process here so that our trajectory is changed and we don't develop further symptoms and lung function deterioration? So this is the concept they are looking forward. So in this context, they have made one approach which is called genomics, that is gene environment over time. So the important thing here is the same gene. There are two people who smoke, and one of them develop COPD, the other don't develop COPD. One of them even less PAC index, they develop lung cancer, but the other doesn't develop. This all depends on your genetic interaction. You have a genetic background, and on top of that, you have a risk factor and the environmental issue over your lifetime that determines how the trajectory is involved. So this is a very nice study. If you see, even in pre-conception stage, they have started. So the pre-conception stage is like if the maternal smoking when they're pregnant, or early childhood infections, low birth weight, all this. So if you can identify what is the factor and intervene early, can you change this trajectory and make it normal? That's the whole idea. So every event, childhood, uncontrolled asthma, so many things, all these events, can we stop this here? Can we make these COPD patients in adult, prevent them, or even prevent them from developing the disease in the adult process? So this is a very nice paper. You can go and read. This is one concept. So in the concept of moving towards earlier diagnosis, so the Gold has introduced another concept. So the first was genomics. Now they are saying gene, environment, risk factors, and then pre-COPD and COPD. So they introduced this concept just to make us aware that we need to catch them early. We need to do something for them early before they get into the final COPD. So in this context, traditionally, COPD is defined as post-bronchodilator FEV1 by FVC less than 70%. That we know. So early COPD, what is early COPD? It is not early, not in the age related. It is related to biologically early, meaning the biological process which starts early. That is called early COPD. Then there is a term called young COPD. So traditionally, we used to think that COPD is a disease above 50 years. So from 2023, the Gold has moved away from that. So we know that 20 to 50 years old people also can have COPD. So they labeled this as young COPD. And then these patients, I told you to remember the three parts of the definition. One is symptoms, the other is structural impairment, and then the lung function impairment. Here, young COPD patients have structural and functional abnormalities. They have either never achieved the normal peak in lung function, or they have a shorter plateau, or they have early lung function decline. They are not diagnosed and treated. So this is one concept which we should be aware of. Again, getting back to the parts of my definition. So symptoms, structure, and function. Keep this in mind. So the next concept is pre-COPD. So they have respiratory symptoms. These patients have risk factor exposure, and their post-bronchodilator FEV1 by FVC is more than 70. So their lung function as per spirometry is okay, but they have a detectable presence of structural functional abnormality in the form of either small airway disease or emphysema. They can have reduced FEV1, decreased DLCO, increased total lung capacity, and it can happen at any age. These patients may or may not develop COPD at a later age. So again, this is, remember, symptom, structure, and function. So the next concept is PRISM. So in this same scenario, they have introduced a concept called PRISM, where pre and post bronchodilator FEV1 by FVC is more than 70%. Their post bronchodilator FEV1 and or FVC is less than 80% predicted. Who are these patients? Their prevalence is around 70 to 20%. They are more in former smokers. They are more in low and high BMI patients. Obesity needs to be corrected in this group. If you have It's more common in females. 40 to 50% of them develop COPD. What is so surprising in this group is these people have a risk for all-cause mortality, and these patients do not die due to COPD, but they die due to cardiovascular mortality. So what goes to say is spirometry is a marker of a global health. So it can indirectly tell you about your general health and other systems also. So this is one message. So how is it useful in your practice? If you're able to identify these patients, at least it's like saying like a precursor, pre-diabetic state. What you do for the pre-diabetic state, you don't start them on any pharmacological therapy, but you identify the risk factors and try to explain to them and keep away from risk factors so that they can, they need not develop the disease, full-blown disease. So early diagnosis has a very significant health impact. This we know because COPD is often underdiagnosed, misdiagnosed, undertreated. So that is why the environmental factors need to be altered. And these precursor conditions open new windows for opportunity for prevention, early diagnosis, and appropriate therapeutic intervention. So add comorbidities to this, then that has a morbidity and mortality. So at this stage, if you have a PRISM or a pre-COPD, young COPD, concentrate on controlling the comorbidities, preventing the risk, avoiding the risk factors, and delaying the progress. So this is how it is. You have a healthy patient, they have pre-COPD, they can later progress to COPD. So can we cut them here? So there is a long lag period of lung function deviation before they really develop COPD. See, you can see here, there are symptoms, but there is no diagnosis here. Then later, only when there is mild, when there is spirometry abnormality, you detect them in the mild category. So can we do something to stop the process here? That is what the earlier diagnosis is all about. So the next, they have a new, the information of spirometry have been updated to include comprehensive information about LLN scores, Z scores. And I think all of you know that LLN is part of all your PFT spirometry interpretation nowadays. But and ATS, ERS are suggesting that don't use the fixed ratio, go for lower limit of normal. That is because your regular spirometry can potentially underdiagnose or potentially overdiagnose some patients, especially overdiagnosis in elderly and underdiagnose in young patients. So we leave this discussion today. I think I would like to know from the panelists how this goes. But for now, Gold has not said anything about LLN. They are sticking to the fixed ratio of FEV1 by FVC. So we will stick to that ratio. So this is a general slide on how to pros and cons are using the fixed ratio and LLN. This is just for the information, but Gold 2025 strongly favors sticking to the FEV1 by FVC fixed ratio, partly because I would say that all the new drugs and all the pharmacological development, all your biologics, everything has been tested on the fixed ratio and not on the LLNs. So we leave this debate for another day. So the next important step in that in the COPD document is pathways to diagnosis. A diagnosis of COPD should be considered. Now you need to have 3 criteria in mind. So the first criteria is respiratory symptoms: shortness of breath, cough, sputum, wheeze, and LRTI. Plus there should be risk factors. It can be either indoor-outdoor pollution, tobacco smoking, or a lot of other genetic, all those risk factors. You need to have 1 symptoms, 2 risk factors, and 3 spirometry is mandatory to establish a diagnosis. To say post bronchodilator FEV1 by FVC less than 70%, you need to demonstrate these 3. So you need to have these 3 criteria to diagnose COPD. So they have introduced a new algorithm for this pre and post bronchodilator spirometry. So your pre bronchodilator FEV1 by FVC, which is less than 70%, then that indicates obstruction. Then you do a post bronchodilator, and that is less than 70%. You can almost always say that COPD is confirmed in these patients. But if you have a post bronchodilator FEV1 by FVC, which is more than 70%, this indicates that it is a volume response. Maybe they have an FVC which is improving. So these are patients who can develop COPD at a later date. So watch out on these. So another part of this is if you have a pre-bronchodilator FEV1 by FVC, which is normal, then practically we can rule out, we can say that there is no COPD, but look at the flow or volume responder. If you look, if these patients have a low FEV1 or they have high symptom burden and your suspicion is high, go ahead and do a post bronchodilator if necessary. This is a new update in the 2025. So now we know that we have moved away from ABCD classification to ABE classification since 2023. So all of you are well aware of this. So I will split it. So again, I think today I have 3 as my favorite number. So the gold ABE initial assessment tool, you need to look at 3 important things. So we know that traditionally only if you have the post bronchodilator FEV1 per FVC, that is not enough. That marker alone is not enough for us to say that this patient has COPD. So you need to do assess the airflow obstruction. You need to quantify the severity based on post bronchodilator FEV1. We know the 30-50-80 rule. And then the next step, you have to incorporate the symptom burden either in the form of MMRC or CAT score and include exacerbations. Then you need to place them in A, B, or C category. And then the pharmacological therapy is defined by placing these patients on these categories. I think this all of you know. And we know that group A has only a bronchodilator and group B is LAMA plus LABA, and then triple therapy in the exacerbation wing E, and single inhaler triple therapy is the way forward. I think all this is there in the old 2023 and 24. So again, this is another update which was in 23 and 24. We know when to use ICS, when not to remove them from ICS. I think all of you will be aware of this. But the only thing I want to mention here is, if there are less symptoms, less bronchodilator, more symptoms, more bronchodilator. Only if only depending on the eosinophil count, you need to think about inhaled corticosteroids. So inhaled corticosteroids alone has no indication. And here, if you see this table, there is no indication for LABA ICS here. We will get into that a little bit earlier. So in this category of less than 100, they are against the use of ICS. But in this category where it is above 300, we can use ICS. So this is how a pharmacological table looks like for a regular patient, stable COPD patient. There are a lot of choices which we can choose. We are spoiled for choices. We have so many combinations day in and day out, and you can use any of them, and their goal does not suggest one over the other. It is a personal preference of what you want to use and what you want to choose. So, so this is one table which has been new, which has been included new. So I was also surprised by looking at, because in the earlier document where ABE, we saw the ABE category, there is no role for LABA ICS here. I thought COPD Dr. Gold has removed, was totally against the use of LABA ICS. So practically that makes sense, because if you want to use LABA and ICS, might as well add LAMA to it. Okay, it doesn't make sense giving only LABA and ICS. But unfortunately, I don't know, in this new 2025, this algorithm has come up. Probably from my understanding, what I think is LABA ICS is the most common drug which everybody uses, from general practitioners to physicians. So maybe they are giving us a direction on what to do if your patient comes to you during your first visit already on LABA ICS. So what should you do? So they say if they have a current exacerbation and if the eosinophil count is more than 100, consider escalating to triple therapy. And if the eosinophil count is less than 100, de-escalate to LAMA and LABA. And there is no exacerbation, then de-escalate to LAMA and LABA and remove the ICS. But in a stable patient where there is no current exacerbation and previously this patient has responded to LABA ICS, and if the patient has high symptom burden, consider escalating to triple therapy. And low symptom burden, consider continuing treatment. This, I think there will be a debate on this, but anyway, let's see how the panel discussion goes. So what is the goal? Once you have initiated the therapy, what is your goal on treating the stable COPD patient? Remember, it is only reduction of symptoms and preventing exacerbation. This stays the same in all the documents. So what next? What do you do next? You assess the patient initially, then the initial management does not end with only pharmacotherapy. There is so much here. So in your patient, you cannot say, I have put you on triple therapy, my job is done, there is nothing else I can do. No, you have so much of other things we can do. Avoidance of risk factors, vaccinating the patient. I love this table, by the way. I think postgraduates, you should go through all this because we miss so many things on our regular follow-up. So Managing comorbidities, very, very important. Cardiovascular comorbidity, lifestyle change, then even pulmonary rehabilitation for a select group of patients, oxygen, NIV, in the appropriate phenotype. You need to review this checklist, adjust, review, and then continue with this if the patient is all right. So don't forget all this in the next visit. So there is no there is no alternative to this. I think this is the one important pillar in COPD management. If you can remove the patient from the risk factor, you are removing the trigger from the inflammation, and the continuous damage to the epithelium stops, and the entire cycle is cut short. So this is the most important thing if you are able to reduce the risk factors. And vaccination, the new update has 6 vaccines. Remember, flu, other than your flu and pneumococcal vaccine, you have the RSV vaccine in patients over 60 years, Tdap, and the zoster vaccine for more than 50 years. So this is the update. So there are 6 vaccines which we need to undergo. And I would say the most underused drug in the history of medicine, I call it pulmonary rehab. So it's such an important decision. So don't wait for the patient to become sick and then send them for pulmonary rehab. It does not work like that. As soon as you diagnose COPD, you need to personalize the pulmonary rehab for them. Either even after an exacerbation, once they have recovered, you should advise pulmonary rehabilitation. It's a drug which no side effects, imagine, and with lot of benefits. So this is one message which even in the initial follow-up, we need to understand and send the patient for appropriate pulmonary rehab. So this is our final picture of a patient who has, so you have a pre-COPD, you have group A, B, and E, you have your inhaler choices. Now we'll concentrate. So what does the GOLD recommend? These are GOLD recommended therapies. So for a former smoker, you can give macrolides. For a patient with chronic bronchitis and exacerbators, you can give roflumilast. And exacerbator, you can add N-acetyl cysteine or some mucolytics. So, and if you diagnose alpha-1 antitrypsin deficiency, alpha-1 antitrypsin augmentation can be the way. So these are all previously evaluated and commonly used. If you have recurrent infective exacerbation, you can have nebulized antibiotics to them. And this is again COPD-A or asthma COPD overlap. These are all the biologics which are being used in this group of patients. And now this is CFTR potentiators and alterators are coming in a big way. These are investigational therapy, which I will tell you in a short while. So that is how it looks. So what happens to reduce mortality? Traditionally, we used to think there is only non-pharmacological therapy which will reduce the mortality. But from the 2023, we know that triple drug therapy, single inhaled triple therapy, from the impact on the ethos trial, that it can reduce mortality. So this is, don't forget this pharmacological part of it, and don't forget the non-pharmacological part in an ideal patient. So this is another phenotype. If you have hypoxic COPD, don't forget to give supplemental oxygen. If your patient is in the hypercapnic, don't forget NIV or there. Depending on the phenotype, please, if your patient has emphysema, heterogeneous upper lobe predominant, then you should go for either lung volume reduction surgery, or there are lots of coils, bronchoscopic techniques which are in the document which you can go through. So now follow-up. Now we have done the initial thing. Now we are coming up to the pharmacological follow-up of these patients. What do the goals say? In the new insights, it's talking about precision medicine. So now, so you have done the initial management, you have done your vaccination, you have done your pulmonary rehab, you have optimized your pharmacological therapy, your avoidance of risk factors, everything. And then if your patient is still dyspneic, then you should do something called a treatable trait target. So you should move forward and place these patients in this 2 categories, whether dyspnea is predominant or exacerbation is predominant in these 2 group of patients. And they are talking about self-management, end of life, and palliative. We'll see in detail about these 2. So what is a trait? A trait can be pulmonary, can be extrapulmonary, or it can be behavioral or risk factor. So it should be treatable, it should be identifiable and measurable, it should be clinically relevant. This is a treatable trait, what they are talking about. So now we are moving into uniformly applicable therapies to some personalized medicine. So why do we need new approaches? So because every individual is unique and difficult, each one has specific needs, and at different points of time, the same patient can have different scenarios. It's like tailoring a cloth to that particular patient. One patient can have COPD with bronchiectasis. The other patient can have COPD with pulmonary hypertension, or other patient can have COPD with sleep apnea. So there are so many phenotypes that we need to tailor our management to each person. And in the same patient, at different points of time, different scenarios, a patient can have smoking as a risk factor at one time. He would have moved away from smoking. He can have some amount of air pollution or a different environment and nothing. So at one particular point, just like your GPS navigation, for a specific to an individual, at that particular time and that particular stage of the disease, we need to tailor this treatment. It's such a heterogeneous disease. So we are having from a group of COPD patients, we try to phenotype. This is the new paradigm shift. So the goal says in the follow-up, you phenotype, make a treatable trait target depending on dyspnea or exacerbation. I would say the sooner the better. So if you phenotype, you can treat better. So some of the traits which I'm not going to go through, you can go and read this wonderful paper where they have talked about pulmonary traits, where for each pulmonary traits, what is the management which you're supposed to do. And for high BMI, smoking, inhaler technique, adherence, T2 inflammation is high. For everything, they have given solution. I would encourage all postgraduates to go and read, because this is a topic by itself which we can talk fast together. So there are pulmonary traits, there are behavioral traits, there are extrapulmonary traits. Each needs to be addressed separately. So these are some of the clinically relevant traits. As I told you, a bronchiectasis patient, bronchiectasis COPD patient may need antibiotics frequently, but whereas a patient with a T2 inflammation will need a different set of category, short bursts of corticosteroids and things like that. So there are clinically relevant traits also. So this is one paper. This is the director of the whole document. You can go and read this paper. So they have extrapulmonary traits, one even with the weight loss, cachexia, underweight, obesity, metabolic syndrome. So each patient is like a tree. They can have so many endotype is actually getting to the biomarker level. The clinical biological pathways, what is responsible for this? One biological pathway is, of course, eosinophils. So getting to the biomarker and then targeting all of those is what all this treatable trait target is. So why do we need to do this endotype and phenotype? Because patients respond differently to different treatments, and there is no one size fits all to this. So how will the future of treatment of COPD will look like? It probably will look like this. I would encourage you to go and read this paper also. Fantastic illustration. So if you have, even for psychological problems, even for a patient who has hyperinflation, see, as I told you, for example, if you take hyperinflation, look at the heterogeneity, whether it is upper lobe predominant, how sick is the patient, whether you want to do bronchoscopic directed technique or you want to go for a lung volume reduction technique. If pulmonary hypertension, place them on the category. So like that, each patient has different needs. So phenotyping, endotyping is the way forward in COPD. So the next, now we have moved away from initial pharmacological therapy. Don't forget that this is over. Now the patient is coming to you on follow-up. So this is a follow-up pharmacological treatment. Remember, in follow-up pharmacological treatment, there is no need to do post-bronchodilator reversibility again. Imagine if you have controlled your hypertension with 3 drugs. Will a cardiologist stop a hypertensive tablet and then ask them to measure the BP? It will not happen. So we are forgetting about this. This is only OAB, is only for the initial pharmacological treatment. Move away. We are moving forward. Now we are coming to follow-up pharmacological treatment. Place your patient, if your patient has dyspnea as the predominant symptom and he is only on LABA or LAMA, then escalate to double bronchodilator therapy. And still, if he has dyspnea, then consider switching the inhaler devices or switching the molecule. Suppose he's on tiotropium, go to glycopyrronium. If he's on if he's on formoterol, you can go to vilanterol. Try all this. Of course, all this you should do along with vaccination, along with all the avoidance of risk factors, along with pulmonary rehab, and all the other measures what we mentioned goes along with it. And still, if your patient is dyspneic, this is what you should go do. If your patient has an exacerbation, and if he's already on LAMA or LABA, if the patient has a eosinophil count more than 300, then you straight away go to triple therapy. If not, if your eosinophil count is low And if he's a former smoker, you can give azithromycin. If he's chronic bronchitis, you can choose roflumilast. These two are there in the old document. But what is new now, they have added ensifentrine to the dyspnea category. And if your patient is already on triple therapy and you have a blood eosinophil more than 300 and still he is exacerbating, then you think of dupilumab. So please remember, all this is after all our initial treatment and everything. This is not upfront. So we'll talk about these two drugs in a short while. So why is so difficult for COPD to develop a new drug for COPD? Because it's a heterogeneous disease. So in disease stage, you have heterogeneity. In your risk factor, you have heterogeneity. You have early versus late, mild versus severe, active versus inactive. And you have so many phenotypes, airway, emphysema, exacerbation, endotypes, and the risk factors are numerous. And all this pathological pathway, finding a biomarker and the endotype is so difficult. That's why a COPD drug, even if they come up with many drugs, you cannot use it for all patients. This is what I'm talking about. So this is not for across the board all patients. We will talk about the drug shortly. So fantastic. This is the novel first-in-class dual inhibitor of both PDE3 and PDE4. Sorry, this is PDE4. So ensifentrine is a drug which acts on PDE3 and PDE4. So it increases cyclic AMP and cyclic GMP. What it does in the airway smooth muscle, it produces bronchodilation. It acts across all inflammatory cells, which are the drivers of this inflammation. So it has an anti-inflammatory effect. And in the epithelial cells, it also has an action on the CFTR gene and produces mucociliary clearance. I think this anti-inflammatory effect is non-steroidal anti-inflammatory effect. This is, we cannot ask for anything much more than this. I think it seems very, very promising and wonderful. Let's see more in detail. So we know that in smokers, you have cigarette smoke produces a dysfunction of the CFTR gene, and it behaves like a cystic fibrosis. Like, they share the common mechanism. They have mucus hypersecretion, small airway inflammation, goblet cell metaplasia, and chronic bacterial infection. So in these group of patients, you have this CFTR corrector, potentiator, and amplifier, which may be helpful. So imagine ensifentrine also activates the CFTR. So that is why it is also having a role in the mucociliary clearance. So this is how did they give approval for this? This is from these two studies called ENHANCE-1 and ENHANCE-2. Ensifentrine improved FEV1 but had equivocal results on symptoms. Imagine there was a FEV1 response of 87-94 ml, and most importantly, these COPD patients had less of exacerbation, less of attendance to the physicians, less of hospital admission, and imagine they had 44% less of exacerbation. This was not the endpoint which they looked for, but additionally, they found that exacerbation also reduced. It looks fantastic. So other consideration, what does we need to do for goal 2025 say about ensifentrine? Can we give it to everybody? So this is the pathogenesis. Read this article. This is also very good. So ensifentrine is a nebulized drug, very, very costly. Right now, not available in India. And I think it costs around $36,000 per year in a patient. I don't know what the cost will be if it comes to India. So where do you place this drug? What do the goals say? So you place it, ensifentrine, in the dyspnea uncontrolled arm where patient is on LABA and LAMA, not on ICS. Remember this. This is in the dyspnea arm. And what do the goals say about it? It has evidence A. It improves, ensifentrine improves the lung function, dyspnea, and health status of the patient. So remember, it is not for everybody. You have to place it at the right spot. So the next new drug which they have talked about is biologic, that is dupilumab. It's exciting. And I think once one biologic is come, I think you will be in line for much more to come. Watch this space. It's going to be more exciting here. So what is dupilumab? Now we know that all the triggers and this alarmins, T2 inflammation. So dupilumab is for T2 predominant people in the exacerbation arm. As I told you, patients already on triple therapy, having a eosinophil count more than 300. That is where you should think about dupilumab. So what does it do? We know from asthma guidelines and people who are treated asthmatics, they will be very familiar with this biologics. So it is a human monoclonal antibody against IL-4 and IL-13 blocker. So this is where it acts and then it cuts off. So it is T2 phenotype of COPD. So where did they give this guidance? They took it from these two trials, Boreas and Notus. They showed that there is a marked reduction in exacerbation by 22%. And over 12 weeks, they also found that FEV1 improved by 160 ml in the dupilumab group. And this is from the GOLD document, reduces exacerbation, improves lung function, and improves even quality of life in patients who are exacerbators and who have a blood eosinophil count of more than 300. Please remember this. So for me, I'm going to throw a personal comment here. So for a biologic, you have a reduction in exacerbation 22%. Very surprising. In asthmatics, if you use a biologics, your improvement will be in the range of 50 to 80%. So I think we should keep this in mind. So word of caution, tomorrow you don't jump and throw these drugs. We need to wait for some more data and availability, and then we need to be cautious on using this. So what about biologics for those without T2 high disease in COPD? I think now the board does not suggest any of this, but watch this space. I know there is going to be in the next document, you will see TESI, which is a blocker of TSLP, and you will see Itepekimab and Toso, which is a blocker of IL-33, and also ST2, which is a receptor blocker of IL-3. These astegolimab and these four drugs will be there in the next GOLD document. This is what is the future I predict. So now pharmacological treatment on follow-up. This is the initial, this is the follow-up. Again and again, I'm stressing, forget about this. Now we are in the follow-up. So now this is where we place the drug. In this dyspnea, this is ensifentrine. Here, this is dupilumab. So however good a drug is, if it is not in the right place, I think it is worthless. So remember, that is why this picture, remember this picture. So even if you have a Ferrari, if it is not in the right place, it is useless. So now coming back to our pharmacological therapy, this is where we were already in all this. Now the new document, ensifentrine. Where do you place ensifentrine? In the group B, not on patients who are on ICS, but here. And then dupilumab in the eosinophilic Th2 pathway. I think all of you are clear with this. Now a little bit about exacerbation. Exacerbation definition, everything remains the same. So exacerbation looks like it doesn't look like a definition, it looks like a description to me. For postgraduates, I have split it into 4 parts. So it is increased dyspnea, cough, and sputum less than 14 days, accompanied by tachypnea, tachycardia, and having systemic and local inflammation. This is what is the exacerbation. I think the word acute exacerbation has been removed, and now we have only ECOPD. Don't call it as AECOPD, because GOLD says it is no more acute. The acute event extends beyond 4 to 6 weeks. And so it is only exacerbation of COPD. And the Rome proposal is what is the new one in the 2023 document. I think all of you know about it. I'm not going to go into all these details. But here, remember, if you want to change a patient from mild to moderate, you need to have 3 parameters. Any 3 parameters is enough. Imagine, even in a periphery, you can diagnose this. If you have dyspnea, respiratory rate, and heart rate itself, you can diagnose. So they added one biomarker, CRP. So we are moving forward in finding more and more to diagnose these patients early. But don't forget, the same symptoms, same picture can be there in patients with heart failure, pneumonia, pulmonary embolism. Cardiovascular risk is high in these patients. Consider differential diagnosis. Do not forget that. So the next is, this is remaining the same. The interventions, the treatment with antibiotics, bronchodilators, everything is the same. Target these patients, the appropriate patient for appropriate therapy, hypercapnia, oxygen therapy, all this in the particular phenotype, everything helps. So all these interventions reduce the frequency. So what is the most common reason for exacerbation is previous exacerbation. So keep that in mind. If a patient has exacerbated, it is like heart attack. You have to take very drastic steps. So if there is a MI, a cardiologist do so much for the patient, whereas we don't. There is, I think there is a study in a Blue Journal where they have said if a patient exacerbates, 1/4 of them get readmitted within few days, and 40% of them are not even alive beyond 40 years. And if in your exacerbation, if you use NIV, that carries a bad prognosis. And even they are markers for mortality and all-cause mortality as well as cardiovascular mortality. These patients are at increased risk for all of these. So exacerbation should not be taken lightly. So this is a new table which they have said. So this is a treatable trait of pulmonary hypertension. You need to categorize this patient. Not all patients need PAH specific therapies. Be very, very specific about it. If your patient has COPD and PH, do not institute PAH therapies in the form of tadalafil, bosentan, and all this. You will be worsening their lung function. So categorize this patient into group 1. If you have group 1 PAH, then according to ESC, according to the European Respiratory Society, you can follow the PAH guidelines. If you place the patient in group 4 PH, then you have to follow the CTEPs and the ERS guidelines. If your patient has got COPD and PH, please look at the treatable traits, phenotype and endotype these patients, and achieve optimum control of COPD than initiating this PH drugs. So the next new thing is cardiovascular risk in COPD is now covered in a new section. So why they are stressing on this unstable COPD, high prevalence of cardiovascular diseases are all there. And in acute exacerbations, they have a mortality, all-cause mortality, paving the way for next exacerbation. So you need to have a low threshold for assessing the cardiovascular system. So you need to do cardiovascular workup in the form of either biomarkers, troponin, NT-proBNP. Don't forget heart failure with preserved ejection fraction. These are all factors, risk factors. And don't forget to talk to a cardiologist, refer the patient for appropriate management. So potential mechanisms, they share the common risk factors, common platform COPD and cardiovascular risk. So they have stressed a lot on inflammation, which is also systemic inflammation, which affects the heart, hyperinflation, which reduces the cardiac output, and hypoxia, which also can produce PH and right heart failure. So these 3 mechanisms are there and they are amplified in an exacerbation. So the next, there is a close relationship. So they have said that, so this paper is quoted there in the reference. You can see this by the size of the circle. You can say that this association is big. How big is the association with COPD? So hypertension, coronary artery disease are the common prevalent things in a cardiovascular patient. So you need to identify all these and treat appropriately. Why? Because you can prevent the next exacerbation. So this is a paper which looked at increased risk of cardiovascular events in a COPD exacerbation. Look at this. There is 20 times increased risk. If you look here, 20 times increased risk in the first 7 days. And the risk continues to increase even at the end of 1 year. And there are 2 times increased risk of MI and unstable angina, 3 times risk of arrhythmia and heart failure, and also 4 times risk of ischemic stroke. So each exacerbation should be taken seriously. Now, there is another concept which they have introduced that is called a novel syndemic approach. So what is a syndemic? Syndemic
we are going way beyond. Sorry to interrupt, but I think we are going way
another 2 minutes, sir. Another 2 minutes. Yeah. So syndemic is you have to look at, before we were looking at COPD as a single disease, and then we looked at comorbidities. Now we have to look as a multimorbidity. COPD is part of multimorbidity disease. And so there will be individual guidelines for all this. We need to incorporate everything to have a optimal management. That is what is important. You have to have a proactive diagnosis and treat everything. On the role of CT, they have said that CT plays an important role. All this is there in the old document. They have just said 50 to 80 with 20 pack years, regardless of years since quitting. Earlier, it was less than 15 years of quitting. It's no need to screen. But now in the new document, it's regardless of quitting. And they have given CT a good multimorbidity. You can diagnose multimorbidities through this CT by diagnosing osteoporosis, muscle mass, and everything. So there is a new this thing about climate change and COPD. We know what affects the external climate, affects our environment in the lung. There's a lot of stress on exacerbations due to indoor and outdoor climate change. I think you can go and read about this. So these are the conclusions. I've just approached all this. So move beyond thinking that COPD is a single disease and then it is the cluster of phenotypes and endotypes. A word about, I end my speech with a word about evidence-based medicine. This is Dr. David Sackett. He's the father of evidence-based medicine. He said that evidence-based medicine is not a cookbook medicine. If you follow the recipe, you will not get the desired result. It should always be using the clinical expertise and share the informed decision with the best available evidence to give a proper decision for our patients. Thank you very much for your patient listening. Thank you. I look forward to a great panel discussion on the new document. Thank you so much for your patient listening. So should I stop sharing?
Yeah, please do that. Thank you, Dr. Tilga Madam, for this super exhaustive kind of deliberation. I hope we have some time left for the discussion, and we'll do some justice to this. I move on to the first question to Dr. Arup from West Bengal, and as I think Tilga Madam has elaborated on this beautifully. But at the same time, I do think that the repetition does help, and it makes sense in many situations. So as we move towards a so-called earlier diagnosis of COPD, can you sort of try and define the terms pre-COPD, PRISM, young COPD, early COPD, etc.? So Dr. Arup, over to you.
Yeah. So Madam has
Yes,
defined all these terms.
Yeah. So sorry for hurrying this because the time consumed. Sorry. Dr. Arup, let me introduce you. You are MBBS, DCH, and MD, consultant pulmonologist, CMRI Hospital Institute, Sleep Sciences. You have done fellowship in epidemiology and biostatistics. That's quite impressive. And a current writer in World Sleep Academy of World Sleep Society. That's a very impressive thing. Wonderful amount of conference presentations, book chapters, and publications and journal articles. With that, over to Europe for the definitions back again.
Thank you for the introduction. So I will be very brief. So mild COPD is denotes the severity. Mild COPD means FEV1 by FVC ratio less than 0.7 and FEV1 is more than 80%. So this is mild in severity. Then we have another term that is called young COPD. So young COPD means COPD symptoms or COPD diagnosis in patients who are aged between 20 to 50 years. So usually previously we used to thought COPD is a disease of the elderly, but now the paradigm is shifting. Then we have the early COPD. Early COPD is very difficult to diagnose actually. So it is the biological early. When you're exposed to the various risk factors, there is some biological changes that leads to pathological changes, that leads to clinical symptoms, and that leads to complications. So there are no biomarker at present to define early COPD. And last, we have pre-COPD. So what is a pre-COPD? In pre-COPD, previously used to be the term gold zero in 2021 document. In pre-COPD, we have the history of exposure, we have history of symptoms like COPD, we have the structural abnormality of COPD, and we have functional alterations, but absence of a fixed airflow obstruction on forced spirometry. That means the FEV1 by FVC ratio is more than 0.7, but FEV1 may be low. But if you do a detailed lung function test, you will get other abnormalities like low DLCO, high TLC, high RV-TLC ratio. As because this ratio is more than 0.7, we cannot diagnose it as COPD, and this is defined as pre-COPD. And PRISM, where we have a preserved ratio impaired spirometry, where the FEV1 by FVC ratio of more than 0.7 and FEV1 of less than 80%. Previously, they used to include FVC also, but now the current definition of GOLD actually excluded the FVC. And depending on if you include the FVC, we can define it as a restrictive PRISM or non-restrictive PRISM. So in non-restrictive PRISM, we have a very high chance of developing COPD later in the course.
Wonderful answer, wonderful, absolutely, and to the point. Thank you for being on time. Thanks a lot. Let me introduce my next panelist, which is Dr. Akhilesh Kunnur. I'm sorry, I'm doing it in sequence. So can I have that slide? Kushi, please. Yeah. So Dr. Akhilesh Kunnur is MBBS from, I can't read that, sorry, MD from Cuttack, then Professor on Amrita Science of Medical Sciences, Kochi, Kerala. So welcome, Dr. Akhilesh, on this webinar. And wonderful number of publications as I see it, more than 52. Your interest is in COPD and pulmonary. Dr. Arup has already alluded to the number of so-called early diagnostic and phenotypes or measurable types. So what would be their what do you think their implication in day-to-day practice as of now? Dr. Akhilesh, over to you.
Thank you. Thank you, sir, for this opportunity and the question. And as Dr. Amitabh told, can I have an introduction about your slides? Nitin sir, slides.
I don't have any slides, sorry.
Okay, okay.
Yeah.
Then, Doctor, coming to the question, thank you, sir, for the question from Dr. Nidina Abhyangar, who is the head
You
of
want me to repeat the question? I can repeat that, because we asked the question on pre-COPD, PRISM, young COPD, early COPD, etc. So how do you feel this will impact our day-to-day practice in the
Yes, sir.
common?
Yes, sir. This pre-COPD, PRISM, and all this may be an early indicator of upcoming COPD. In pre-COPD, there is no spirometric data, evidences of COPD, but there are some other evidences like emphysema and other factors like factors. And the implication is that there is still scope for risk factor assessment and early intervention assessment, like early lifestyle changes like avoidance of smoking, daily exercises, and all these things can be incorporated into the lifestyle, so that we can halt the progress from pre-COPD or PRISM to other COPD. And as Dr. Tilaga madam told, PRISM is having associated with cardiovascular comorbidity. So it actually indirectly reduce the mortality by preventing the comorbidity also. Thank you, sir.
I think so wonderfully said. I think as you can say, both of you have put this so very succinctly. I think two take homes are A, if I diagnose them early, I can prevent progression. And if I diagnose them early and that diagnosis is relevant, then I possibly can save them from other comorbidities, because it is not only a lung disease, but it's a systemic disease as well. And the systemic deaths, for example, a cardiovascular morbidity is much higher than in the early phase particularly. So I think these two are possibly the key take-home messages. I come to Dr. Rishi. And let me introduce him. Can I have Dr. Rishi's introduction slide, please? Rishi, thank you for that. Dr. Rishi Kumar Sharma, a professor and Department of Medicine, Gitanjali Medical Hospital, Udaipur. He has a number of presentations in state and national conference, panelists in NAPCON, conducted PG quiz in the national and state conferences, nearly 16 publications, number of fellowships, and his area of interest, once again, are PFT, and I think we'll come to that as important. So let me ask this question, Dr. Rishi, to you. What changes do you think are most relevant in this new 2025 statement? And do you think this Z-score and lower limit of normal in the new update relevant in the practical sense? Are we going to use this, or will just be it'll just be a pipe dream?
Thank you, sir, for the question. There are three methods for defining the abnormality. First is we can use fixed ratio. Second, we can use lower limit of normal. And third, we can use Z-score. Before the recent guideline by the Gold, the Gold was silent about the use of lower limit of normal and Z-score. But recently, the importance has been mentioned in the guideline. The problem of using the fixed ratio is that it overdiagnoses some patients as having COPD, especially in elderly people, and it underdiagnoses some patients in younger people. The fixed ratio is dependent on the various variables, actually. So, still, Gold guidelines recommend that the using the fixed ratio is non-inferior to lower limit of normal. But the problem with using the lower limit of normal and Z score is that both these parameters depend on the reference equations, which are unfortunately not widely available throughout the globe. So we hope that once the reference equations are available, we will be using Z score or lower limit of normal more frequently. But till now, gold guideline still recommends as the fixed ratio.
So it still remains that the gold standard remains at 70% and below, and post bronchodilators. So I think that's the key take home. But at the same time, I think we will probably look forward to LNN and Z scores and many more, and we will be coming to that. So I think I move on to the next question, which brings in a little more controversy. And let me introduce Dr. Radhika Sharma. Can I have her introduction slide, please? Aditi? I'm sorry, I'm introducing that because we wanted to start the discussion as early as we could. If I can have Dr. Radhika's introduction slide, please. Yeah, thank you, Kushi. I think it will be coming up soon. Yeah, possibly the youngest in this. She is MBBS, MD, FI, current and past affiliation. She is a consultant pulmonologist in Apollo Hospitals and Clinics, founder Yellow Clinics and Diagnostics in Kolkata, Hyderabad. She is a member of ERS and IS, 3 publications and a case report. She is an interventional pulmonologist and interested in allergy and sleep medicine. So Radhika, over to you. This is something for the, not necessarily for only the young ones, but those who are inclined towards the new. And I hope this question goes well with you. Is there a role of something like DLCO, impulse oscillometry, or airway oscillometry in the initial diagnosis of COPD as per GOLD 2025? We are not talking about what's my opinion or your opinion is. We'll but GOLD 2025 is there.
Sir, first we'll talk about DLCO. So DLCO, initially we were only doing it if we wanted to differentiate between emphysema and chronic bronchitis. Or we were looking at other conditions like ILD associated with COPD. But now what GOLD says is that you should be doing DLCO in all the patients where they have dyspnea, which is in proportionate to their lung function. So in those patients, if you do DLCO and DLCO is less than 60%, then that says it's independent risk for hospitalization, death, irrespective of what their lung function might be. And also it says they did another study and they said it's an independent risk factor for airway obstruction and hospitalization. So now we can use DLCO as an independent or prognostic marker for monitoring the COPD patient. Now coming to oscillometry, they've not mentioned too much, but they've just, so see, oscillometry is easy. It's a very easy tool. You can use it in all the patients, younger ages, and even patients who are very dyspneic. Because it's not an effort dependent. It can be done with the normal tidal volumes. So if we do oscillometry, it's a very good predictor for your small airway involvement, which can be easily missed on your spirometer. Especially in the non-smoker COPD, we see a lot of small airway involvement. So that's where the role of the oscillometer comes in. And over time you can measure the resistance and you can see how the treatment is, how the patients are responding to the treatment.
I think wonderfully said. I think there is a message in this whole thing is the DLCO, possibly a tool for prognosticating. Isn't that what you're saying? I think
yes, it is, but then it is a prognostic tool. That's what 25 says, because a lot of studies has been done.
I think it will possibly emerge much better. And as I see it, I've been using Impulse as well as FOT in my practice for last 3 years, and an early diagnosis, a very early diagnosis for that matter, very sensitive tool. So I think much more sensitive than the spirometry alone. So I think, we are talking of a lower limit of normals and Z scores and 0.7 and all that. But with a normal spirometry, and we are also talking on pre-COPD and things like that. So at an early detection of obstructive disease, way before a spirometry actually shows abnormality, I think impulse will figure out. I think just let us give it 2 to 3 years to gold, and they will come back to us and say, now we start using it, and it's possibly, you can make a more confident diagnosis of an obstructive disease. With an impulse we'll come back to you, madam, because the next question is directed to you only.
Okay.
So this is something which is, I wouldn't say controversial, but it is being something which is now the gold has sort of saying a complete no to. That is ICS-LABA in the terms of, in the new algorithm, there is a clear-cut no when it comes to a pure COPD. And if you really see, all over the world, it's not only Indian phenomenon, all over the world, ICS-LABA seems to be used in all kind of obstructive airway diseases, be it COPD, be it asthma COPD overlap, be it COPD A, if you want to call it that. So one way or the other, people are using ICS-LABA as a standard of care, one way or the other. I wouldn't say standard of care, but a standard of practice. And so in which way, where do you put this ICS-LABA? Do you think still this is useful in your practice, the new algorithm, or we'll still continue using ICS-LABA?
Thank you. So one comment about the previous discussion. I think CT scan is available in all places nowadays. To get a good spirometry is difficult. So in major cities, if you see, CT scan is available, which can pick up small airway disease if you properly, if you do it with inspiratory, expiratory, and typical protocol.
We'll be coming to CT eventually, madam.
Yeah. So coming to the question on ICS-LABA, I think that's the most commonly prescribed, as you said, everywhere. So earlier, last year, I think Gold Document bravely took the decision of eliminating ICS-LABA. And suddenly they have realized that everybody seems to be on that when they come to us. So they have said that if there are no, the de-escalating part is only for ICS in COPD, that we should remember. It is not for LAMA or LABA. Only the ICS can be de-escalated if there is no exacerbation. But then there is a caveat here, I feel. So if you de-escalate, is it because of the ICS the patient is not exacerbating? Or is it not even COPD? Is the patient is mainly an asthmatic who has been misdiagnosed as COPD? So all these issues are there. I think it is like you have to individualize this, and you have to change to LAMA-LABA, and then see if the patient exacerbates, and then do some more on this, do some more investigations to really eosinophil count and other things to really see whether ICS should be kept there or not.
I think beautifully said. I think that ICS controversy will remain. It will keep boiling over because lot of the world has asthma in the early ages, and eventually some of them will become COPDs. Not everybody. So COPD-A will become a subset of it. Smokers will have some amount of eosinophilia in some of these patients. So one way or the other, they will qualify for inhaled steroids one way or the other. So I think that controversy will keep boiling over. And I think it's a very prudent thing to say that if I'm dealing with a pure true blue COPD, which is entirely related to a noxious particle exposure, and there is no eosinophilia whatsoever at all, then LAMA-LABA become the first choice, of course, and then ICS gets added only in exacerbators. So I think that's a very valid statement, and I think Gold is doing right because they are not GINA. GINA has to say ICS as the first thing. Gold doesn't have to say ICS as the first thing. It makes no sense that they say that, because then they're not talking of the right disease in the first place. So I think that's the right statement. Arupa, I come to you again, and this is very important. What is the role of CT chest in a stable COPD patient? In what way would it help in COPD management? You advocated early. What is your practice today? I mean, apart from the fact that everyone 2025 what is doing, I would like to know that also. And what are you doing also in your?
Routinely, we do not need a CT chest for diagnosis of COPD or evaluation, but in certain situations, definitely we have to go for a CT chest. And in Gold, recent Gold, they mentioned 3 indications where a CT chest can be done in a stable COPD. First, if you want to make your differential diagnosis as your working diagnosis, like if the patient is having a frequent exacerbation or having an excessive cough with sputum production, like you want to rule out bronchiectasis or you want to rule out any atypical infection, you can go for a CT thorax. Sometimes the symptoms are out of proportion to the severity of the FEV1. Then you have to go for a CT thorax to rule out whether the patient is having a pulmonary vascular disease, acute or chronic, or patient is having chronic CPFE like things. So you have to rule out all these things. So for a differential diagnosis, this is the first indications. Now, if you're planning a lung volume reduction surgery, you have to document patient have hyperinflation, a predominant upper lobe emphysema, so you have to go for a CT. And the last but not the least, but it is not relevant for our country, for lung cancer screening program, which is relevant for USA, you can go for a low-dose CT, and that low-dose CT may actually pick up some hyperinflation, emphysema, or chronic bronchitis like thing in the CT, and which can actually give you additional information. Now, there are some exceptional cases also where you can go for a CT. Like if you have a software which can measure the amount of emphysema, if you have a parametric response mapping, which we have in our hospital, you can go for a CT to define the extent of emphysema so that you can follow up these patients in future to see how much they have the disease has progressed or regressed. So these are the main indications of doing a CT.
I think it's wonderfully said, and at this point in time, it remains still a minority decision to go for a CT as a primary tool to diagnose it. I think spirometry still remains the best. And it still gets so badly underutilized. I see patients who are in the hospital with exacerbation in the ICU, and they have not had a single lung function test measurement ever at all. And they possibly had 4 or 5 CTs in their lifetime, one way or the other from COVID times. That has increased exponentially. So one way or the other, we probably see an overuse of CT and an underutilization of CT in the true sense. Underutilization because we are not using the right tools to diagnose COPD in the truest sense of the word, because there are low quality CT scans which are 3rd or 4th or 5th generation CT scans and not the top of the line. The latest are not being used. So I think one way or the other, I think that remains a bit of a sad story that we have a CT in a COPD patient and we can't make much use of it unless until we use the right algorithm, right technique, and right resolution. So the MDCT makes a lot of sense. So I think that brings me to there's a question directed to somebody in Delhi. So I hope I'm getting it right. Rishi, are you from Delhi? No, you're not. Sorry. Can you unmute yourself?
From Udaipur.
Okay. So you're close by. Okay. So I'll direct this question to you rather than Akhilesh because he's from way south down. So avoidance of risk factors is one of the main pillars of COPD management. What precautionary practical measures you will advise to a patient who is living in Delhi? Don't go out. Don't live there.
No, sir. Just use the mask. First is just use the mask. Because, sir, definitely, sir, pollution is increasing in the major cities. And the single measure we can use that while going outside, we can use the mask. Otherwise, sir, even if we are living in our houses, we can use the air filters. And many of the people who are living in the Delhi, they are using it.
Absolutely. Yeah, I think the environmental menace, particularly in the north part of our country, seems to be growing little out of proportion, particularly Delhi, because Delhi brings in a lot of that parali burning and all kind of biomass exposure. So all that, the air quality index is always miserably low. So particularly in these months, next 2 months. So possibly, I think that's a message. In fact, very frankly, I live in a city where the AQI rarely exceeds 200, rarely in a year. The worst I've seen is 220, 220, 230. That's the worst. And we believe that we are blessed with that kind of air quality index. It's not great. Very frankly, we have never reached 60 also in the lower side. So at the same time, we remain a polluted city as a city in Pune. The pollution is increasing because of the vehicular transport and the new constructions which are going on, and the entire country is going through that change of massive constructions going on everywhere, all kind of metros and whatnot. So one way or the other, we are going to be having increasing ambient air pollution in the next decade or so. At the same time, the balance is in favor of avoiding exposure to the ambient air pollution. And I think what you said is wonderfully right. Would you propose an N95? Insist on it? I would love it to do that, but I couldn't live with it for a very long time, even during COVID times. Very frankly, it's not a very easy thing to live with it.
I think a simple 3-layer mask is
even a simple face mask is good enough. So Akhilesh, I have switched this question from Rishi to you because he's in Jaipur and you are down south. So I think let me ask you that question in the sense of. What are the anti-smoking interventions which are recommended by Goal 2025, and what do you usually do in your practice in the smoking cessation scenario?
Whenever any patient comes to us, we will take it as an opportunity for assessing whether they are a smoker or not. And each occasion, we will take this as an opportunity to have a brief counseling. And hello, am I audible now? To have a brief counseling, and whether we can assess that whether they are in pre-contemplation stage or contemplation stage, etc., so that we can go, we can counsel them, motivate them, educate them regarding the benefit of smoking cessation. And we can also, in my practice, I usually used to assess the Fagerstrom dependence test also, so that we can assess the dependency, and depends upon the dependency test. If needed, we can have a pharmacotherapy for smoking cessation also. Suppose if it is a moderate or high dependency of there is a high relapse in previously, high relapse are there after a quitting attempt, then most of the time the pharmacotherapy may be needed. Most of the time we may have to involve the family members also in a part of the smoking cessation intervention. And all the ex-smokers who are already having a history of smoking and having COPD now are already in pulmonary rehabilitation program. So in a group cessation program and group pulmonary rehabilitation programs will improve the adherence to these smoking cessation interventions also.
Beautifully said. I think that the 4 points which are ask, advise, arrange, and assist. I think they go a long way, and those 3 minutes spent with talking about smoking cessation go a long way in a patient's lifetime in the terms of making it better, make them live longer, walk more, do more, and all kind of things, very, very frankly, and not die of lung cancer and one way or the other, or COPD either way. So I think very, very beautifully said. Radhika, I come to you about vaccinations in stable COPD patients. The goal 2025, and what are you doing in your real life scenarios at this point in time about vaccination?
I think ma'am already covered this.
No, you can be brief and just.
So influenza vaccine, I think we've been doing for a long time now. Yeah, influenza vaccine yearly we have been doing. Pneumococcal also has been there in the previous guidelines, which has been going on now. So now coming to the DTaP. DTaP, we are giving to the patient who not got the vaccination in adolescent. So a lot of patients, because they don't have the vaccination status, we have started vaccinating. COVID-19, they mentioned in 2025, but we are actually not vaccinating for COVID anymore in our setup. Coming to RSV, we vaccine according to the guidelines. Everybody who's more than 60 should be given RSV vaccine. There's a lot of studies which shows if you are vaccinating the patient for the next 2 seasons, they didn't have any symptoms, or the severity of the disease was not so much. Now, coming to the last vaccine, which we have implemented in Apollo at least, shingles or the vaccine, we are giving for everybody who's more than 50 years, 2 doses have to be given. You can give it 2 months apart, or it has to be given within the 6 months time frame. I think that's all. That's all the vaccine.
If I really want to add something to this, we are in the process of phase 3 trial with even RSV and a combined human metapneumovirus vaccine. So we are, as a center, we are investigating this. We are in a phase 3 trial, and I think those results are in the future. So right now, at this point in time, whatever you have said is right. RSV vaccine largely not available in this country. So I think we are really stuck with those 4 things which you said. Tdap, whenever it is relevant. Influenza vaccine annually, no questions about that. Pneumococcal vaccines, right now we have to do those 2 things because the polysaccharide and combination with Prevnar 13 or whatever that. So conjugate vaccine 13 is relevant. Once we get 20-valent conjugate vaccine, there will be a single vaccine in that. And of course, shingles. We have to cover that. So I think these 4 are sensible. Shingles remains a little expensive, so I'm not able to practice in all my patients at this point in time, but I advise to all my patients. So I think one way or the other, because most of the other vaccines are well within the reach of middle class patients, which I have in majority. But
also, if you say 5 vaccines.
Yeah. So yeah, absolutely. And the human metapneumovirus can possibly emerge this kind of a situation. So I think, Thilga madam, this is gold traces. I mean, you beautifully showed those slides on treatable traits, phenotyping and endotyping. So should you be doing this in initial patient visit, or do you do it in over a period of time? Where do you place it? I mean, the phenotyping, endotyping business, is it right up front on day 1 or over a period of time? And follows.
Actually, this phenotyping, endotyping, and treatable trait, Gold has suggested that initially it is not, you need not phenotype, endotype, do everything. I think only in the subsequent follow-up, if your patient is not doing well, then you should go for all this. But indirectly, I feel now we know that eosinophil is upfront. Eosinophil biomarker is upfront in COPD diagnosis. So that is one way of phenotyping the patient. Is indirectly they are saying that you phenotype later, but then they are also doing phenotype upfront. So they have doing it in a small way, I believe. So I think and the most important point here is, we don't see, as pulmonologists, I think all of you will agree, that we don't see patients in group A frequently. We see patients who are exacerbating, who are already on triple therapy or on group B. So we already treated patients. So we upfront, I think we are in the stage where we need to phenotype or endotype to differentiate whether they have other multimorbidities. Another thing, bronchiectasis COPD, OSA COPD, pulmonary hypertension COPD, cardiovascular COPD, all have different mechanisms of treatment, different drugs to target. So it's really a heterogeneous disease where we cannot give a single answer to the patient. So I would suggest phenotyping upfront.
So wonderful to think of phenotyping upfront, but at the same time, I think hold your enthusiasm back and say, let me look at the lung function first. Look at the trend, maybe do a breathometer charting for a month or so and see what kind of improvement am I getting. And if I'm having a dramatic improvement, this is something which was a COPD-A, which was undertreated for years altogether, and all said and done, this was not a true COPD. So I think one way or the other. So the phenotyping, endotyping business starts in your mind on day 1. It becomes a reality in practice over a period of time. I guess I'm right in saying this. So, Arup, I come to you with the next question. During the exacerbations, this so-called Rome proposal help us in better categorizing these patients? Any new updates on exacerbations in Gold COPD 2025 guidelines?
Right. So from 2023, we have the definition of exacerbation has changed. The previous definition, which was before 2023, that is 2022 definition or 2021 definition of COPD, was very postgraduate trainee friendly definition. This is very easy to remember: an acute worsening of respiratory symptom results in additional therapy. So, but this definition is grossly inadequate. So that's why we have a change of definition from this definition to the Rome proposal, which was proposed first in 2021, and Gold has taken this definition as exacerbation of COPD definition from 2023. So this definition has been described by Tilagavati ma'am. So this definition contains the symptoms, it contains the time frame of the symptoms, that is 14 days, and it contains the signs like tachypnea, tachycardia, and it also contains the pathological thing, that is the inflammations, and also contains the etiology of this exacerbation, like airway infection or pollution exposure. So this definition is definitely better than the definition we used to use previously. And there is also a change in the categorization of the severity of exacerbations. The previous previous method of categorizing exacerbation severity was a retrospective one. So whether it was treated with antibiotic along, so previously it used to be 3. So first is only bronchodilator treatment, that is a mild exacerbation, antibiotic and steroid, moderate exacerbation, and hospitalization or severe exacerbation. But now we have a 6 criteria proposal for mild, moderate, severe exacerbations. And this is much more objective. And I think categorization of exacerbation is important, because by defining a moderate or severe exacerbation, actually you're placing the patients either in the category A or B or E. So this definition seems to be much more perfect than what you used to use previously.
Yeah, I think it's a work in progress as I see it, but I think we'll get it there one way or the other better over a period of time. I think we are moving in the right direction by redefining the exacerbations in a more correct way in the terms of what will have a prognostic implication of that exacerbation. So in the long term, very, very mild exacerbation, which was like cough for 2 days, will mean differently, and exacerbation which was relevant in the clinical sense will be a different one. So which will have a prognostic implication. So I think these are two different things, and over a period of time, I think this will keep evolving. I think we have sometimes we'll keep going back also to the old definitions, but one way or the other, I think this is a work in progress. This brings me to the next important thing is after an exacerbation, when you this is for Dr. Akhilesh from down south. After an exacerbation, when do you follow up patients, and what is your hold and advice on preventing the next exacerbation? So I think, I mean, are you? I mean, in simple words, we are asking a question. After the exacerbation, are you going to add ICS or not? I mean, in the simplest words, but one way or the other. So please.
Yeah. After exacerbation, first of all, after exacerbation, the need of follow-up is, first of all, to maintain a post-exacerbation quality of life, to prevent further exacerbation and prevent this hospitalization, etc. So that initially we have to see whether the patient is coping with the medications, whatever we have suggested. That follow-up should be minimum within 2 weeks itself. So that whether the patient is adherent to the medications, inhaler techniques, and whether the patient is still smoking or not, or whether they are avoided smoking cessation. And it's an opportunity to start early rehabilitation. There are controversy there whether it's early or not late, but still I believe that slight early rehabilitation for familiarizing will be helpful, and optimize the medications. If there are more number of exacerbations and the follow-up parameters shows that some eosinophilic inflammation, definitely we can add on a triple inhaler or LABA, one ICS combinations also. The next follow-up probably depends upon the individual discussion, but within 3 to 6 weeks, we should have another follow-up, and we should ensure whether the oxygen therapy or BiPAP can be tapered or not, depends upon the status of that time, and patient is adhering to the rehabilitation, vaccination has been taken or not. These all can be into the, also we have to assess the comorbidities, especially pulmonary arterial hypertension, because most of the time, this pulmonary arterial hypertension presenting at the time of exacerbation may not be, we cannot take it in as account. Post exacerbation, we should again check for an echo during the follow-up, so that we can categorize that whether patient is having actually COPD associated PAH or not, because at the time of exacerbation, patient will have a chance of PAH. So these are the factors we have to see in exacerbation during follow-up, coping up the medications, adherence to the inhaler technique, smoking cessation, rehabilitation, vaccination, tailoring or optimization of the NIV and LTOT strategies, etc.
I think wonderfully said that, you are sort of summed up the whole scenario in one sentence. The last sentence that you said beautifully sums up in saying, can I prevent the next exacerbation? And I think, what can I do to do that? All that is beautifully summarized in your last statement. I come to the next question, and it's a bit of an overlap about your PH statement, which Akhilesh you said. Rushi, I asked you this question. There is a new section on the cardiovascular risk in GOLD 2025. How often and what percentage of your patients do you refer to a cardiologist actively? What will be your best advice on beta blockers? These are two sub-questions to this.
Sir, regarding the first part of your question, if I go by the guidelines, GOLD guidelines say that about 20 to 70% of COPD patients are having systolic or diastolic heart failure. At the same time, if I talk about the exacerbation, about 40% of patients who are mechanically ventilated because of exacerbation, they will be having associated left ventricular dysfunction. And during the exacerbation and after, say, 3 months after discharge, the patients are having a high risk of developing ischemic heart diseases like myocardial infarction and stroke. So yes, there are higher chances of cardiovascular comorbid conditions in COPD patients. Regarding the second part, how frequently I refer them. So, sir, if my patient is having, say, any symptoms or any signs of cardiovascular involvement in form of, say, pedal edema, say, enlarged JVP, say, palpable liver, or the patient is not improving despite the optimal COPD management, I would definitely like to seek the help of my cardiologist patient. Regarding the use of beta blockers, sir, they are very safe to use in COPD patients. And if the cardioselective beta blockers are being used, they are much, much safe. So no need to be apprehensive while using these drugs.
Very well said. I think we don't have to refer everybody to a cardiologist, but at the same time, there is an appropriate subset of patients which will go to the cardiologist, and rightly so, beautifully said. Dr. Radhika, I come to you. When do you refer to a patient for a pulmonary rehab after an acute exacerbation, and what all do you think are the relevant components of pulmonary rehab in the true sense? And of course, then what are the benefits naturally? So can you elaborate on this?
So for pulmonary rehab, in our setup, we see the patient after an acute exacerbation, once the patient is out of ICU and once the patient is stable, we normally start with the exercises. But we obviously do just walking, 6-minute walk test, all that we do before we discharge the patient. And most of the studies say it is always better if you start the pulmonary rehab within the first 4 weeks after the patient is being discharged. So coming to the component of pulmonary rehab, everybody, all of us, mostly I also started learning, I thought pulmonary rehab is only exercise. So there are different components of the pulmonary rehab, exercise being the one and the most important, but then there is your patient education. So when you come to patient education, it is the patient is taking the inhalers, the adherence, the technique, the mucus clearance techniques, then the pursed lip breathing, diaphragmatic breathing, everything comes in that education. Then coming to the nutrition, which is very, very important, because most of the patient, we have COPD patient, they'll have muscle wasting, which is one part of the program again. Then there is social support or psychosocial path, where because most of these patients are very, their activity is very limited, so they might be having depression and anxiety. So it's very important to address that. Then coming to the last one, smoking cessation. So pulmonary rehab ideally should be done for the period of 6 to 8 weeks. So how it is done is 30 to 40 minutes of session can be done. Mostly we say 4 times a week, and 2 sessions should be it should be supervised. And then coming to supervised, so this is we start. So we have upper limb, lower limb, and then you have the inspiratory muscle training. So it targets both the endurance and the strength. So you're talking about the upper limb, then you can just start with cycling, walking. All these things can be done. Coming to the lower limb, upper limb would be you make the patient sit. They can just extend their arm, or they start doing a little bit of weight, assisted or non-assisted. Both can be done. Lower limb is all your treadmill that you do, 6-minute walk test you can do. You can use the cycling, walking, all that can be done. Then coming to the ventilatory inspiratory muscle, that is basically for your, so in that patient will have a handheld device, and so you do the breathing exercise against resistance. Coming to the last one option is also there, which is called for very sick COPD patients, we have something called as neuromuscular electric stimulation, which is reserved for the very sick COPD dependent patient, where the activity is quite limited. And coming to the advantages, if we see, it improves the quality of life. It increases the 6-minute walk test. The patient's dyspnea will come down. The quality of life is improved, and also the exacerbation will come down slowly, but it does not increase any FEV1 increase. We probably will not, significant increase will not happen, but it can help with the decline of the FEV1.
So I think
patient should be encouraged, even after 8 weeks, he should be encouraged to have a active lifestyle.
So I think we have audience questions, and Bhavyaja, he had asked questions about the pulmonary rehab, and I think Radhika, you have cleared most of their doubts. I have no doubt in my mind on this, and I think it will stimulate them to think about pulmonary rehab in a more positive way as we go on. So Tilga madam, I come to you with this idea of what is the evidence of mucolytics and antioxidant use in COPD, and what is your take on the current 2025 recommendations on this?
As far as the gold document says, there is no great recommendation for mucolytics and antioxidants. It gives low quality evidence, like evidence B, not evidence A. And it is only for a select group of population, not for everybody. So if you have a phenotype, which is chronic bronchitis type and things like that, then in that phenotype, you can try. They also suggest that it is one of the component which can reduce risk of exacerbation also. So we should keep all this in mind, and it's not for everybody, it's only for a select phenotype.
I think that makes a lot of sense actually. And I'll extend that question a little bit and add some more drugs for Dr. Arup. This is the question for you, that possibly the most commonly prescribed drugs like darifylin, asavirapyrin, where do the gold 2025 put it in? Sustained-release theophylline and whatnot. I mean, and do you recommend them using them in severe COPDs or during exacerbations? And what do you think their advantages and disadvantages? And of course the evidence as we say it.
So Gold was never very fond of this non-selective PD inhibitors like theophylline or acibrofylline. And in the current recommendation also, they have negatively and cautioned using these drugs. But I think in our country, these drugs have some role to play, especially those patients who are having dyspnea in spite of using the inhalation technique properly, in the proper dose and the proper form. So definitely in our country, we use it, but according to Gold recommendation, there is no such recommendation to use these drugs. So gold only recommended this PDE4 inhibitor roflumilast for a group of patients like who are a frequent exacerbator having chronic bronchitis phenotype and FEV1 less than 50%. And this time they have also came with these drugs PDE3 and PDE4 inhibitor ensifentrine. So these two drugs they only recommended as a phosphodiesterase inhibitor, not the theophylline acebrophylline we use in our country.
What's your practice? I mean, I'm going to be a little controversial, little more than that.
So,
I mean,
I usually use it in the dyspnea trait. Definitely, they produce symptomatic relief in the low dose, not in the high dose, in the low dose, and especially if did not have any cardiac risk
that's what
factors.
my practice also is that, use a low dose and a sustained release and see after 4 months, 4 weeks or 6 weeks, the patient starts telling you whether it is making a meaningful difference to him or not. And if it is making a meaningful difference, I'll continue. If it is not, then I'll probably withdraw it. And if I'm really suspecting a toxicity, I'll measure the levels. Theophylline luckily has the levels which are measurable. So one way or the other, you can guide it prevent it from the toxicity. Because I have seen theophylline deaths in the early part of my career. And I'm sure some of you have at least heard of those stories, the younger ones also. So I think one way or the other, we have a better tool of measuring theophylline levels if you want to use it. So I think I wouldn't throw it into a dustbin at this point in time, but at the same time, I'm not going to take it on my head and say this is number one drug. This is an additional adjuvant drug beyond everything else I can do. LAMA, LABA, a relevant dose of ICS, the lowest possible dose of all that, all the rehab measures, everything else, and then a little bit of theophylline, which is makes sense to some of these patients. I'm going to ask the next question to I think to Akhilesh, briefly discuss the role of home oxygen therapy and NIV in COPD patients and when and how you advise these people. You're on a mute, Akhilesh.
Okay.
Yeah.
Sorry, sir. Long-term oxygen therapy is being widely practiced over the few years now, and it has shown that there is some survival benefit in certain selected COPD patients. So if the patient is having a PaO2 less than 55 millimeter Hg or saturation less than 88%, at least twice during the last 3 weeks, that is one of the indications for long-term oxygen therapy. Or if there is a PaO2 with 55 to 60 and associated with any polycythemia, pulmonary arterial hypertension, that's another benefit of long-term oxygen therapy. During exceptional desaturation, it does not have, there are not much studies whether they are useful or not, but for as a routine practice for long-term oxygen therapy, definitely it is indicated. Second thing regarding NIV, again, NIV in stable COPD, if there is a persistent hypercapnia, that is a PCO2 more than 55 millimeter in daytime, that is one of the indication for nocturnal NIV, and also sometimes if associated with a OSA COPD overlap or obesity hypoventilation syndrome with the COPD overlap, in this case also, sometimes we may have to give NIV in COPD.
Beautifully said. I think, do you do it after one exacerbation or two? Because Gold seems to be, talking about the first major one way or the other. So, 2025. So, do you have a take on that? Do you do that?
No, actually,
bad prolonged exacerbation and right up front, or what is your take on it? NIV, I'm talking.
Sir, after exacerbation, during the follow-up, we have to reevaluate whether the patient actually still needs this oxygen therapy. So during at least 1 or 2 follow-up only, we can decide whether the patient needs a long-term oxygen therapy.
I think both are correct in that sense, both for long-term oxygen therapy as well as for NIV. I will take a call not immediately because so many times I have said lifelong oxygen therapy and after 2 weeks I was proved wrong. And lifelong NIV and I was proved wrong one way or the other because there is a bounce back from the body and many patients do not recur again, or they don't exacerbate again, and they don't get that kind of a hypercapnia or that kind of a hypoxemia, either ways. So I think we can take it with a pinch of salt, whatever that is being told to us. So Rushi, this is a question to you on what are the real pharmacological or non-pharmacological measures which Goal 2025 suggests, which will reduce mortality in the true sense, because that's the bottom line, isn't it? We are talking of any drug which changes mortality is the best, kind of a recommendation. So there's something figure out there.
Sir, regarding the pharmacological therapy, the results of ethos and impact trial showed that the triple therapy, that is LABA, LAMA, and ICS, resulted in reduction in the mortality. Among the non-pharmacological measures, the smoking cessation, if the patient has undergone 12 weeks of smoking cessation program, it results into reduction in the mortality. At the same time, if the patient has undergone pulmonary rehabilitation within, say, 4 weeks after the discharge, it also results in the reduction of mortality. If patient is on long-term oxygen therapy, then results have shown that there is a 41.6% reduction in the mortality. A patient on NIV and a patient who has undergone lung volume reduction surgery, they also will be having reduction in the mortality rates.
So very well said. I think the LTOT is a caveat is that you have to choose them correctly. Somebody who say 92 and a little extra breathless and takes oxygen, that doesn't really improve survival. But somebody who is consistently below 88 saturation or a PO2 below 55, and then it's getting corrected to more than 88 or more than 55, then it makes mortality difference. So I think that has to be taken with a pinch of salt, that a lot of people will be over worried and anxious after an exacerbation to use oxygen at home. Maybe some of them will qualify, some of them will not, depends on, and though you may initiate it, but I'm not in the terms of practical reality in India, most of our patients are buying home oxygen concentrators. So what I suggest to them is, for majority of them, is they take it on a rental for a month. Let's evaluate it at the end of 1 month, maybe even 2 months. And after 2 months, let's not evaluate any further. If you really need it, you are going to need it for a long time. So I think then the LTOT is better purchased rather than rented. So I think that's the practical advice I give to majority of my patients. And I think it works out. So for majority of them, it makes... Yes, please.
And there are specific indications given by the GOLD guidelines in whom we should start the LTO.
Absolutely. I think, Radhika, I come to you with one of the relevant questions, very controversial one. Treatment algorithm for pulmonary hypertension has been sort of updated. How often in your clinical practice in this so-called very controversial group 3, do you treat? Assessment is more or less done for everybody, but how often do you treat them and initiate therapy?
So now I think the GOLD has given 3 classes, and they said it is the treatable causes of PH. So they put group 1, which is again confusing. They put COPD and PH and put it as group 1. Then they say COPD with the CTEF is, again they described it. Then the third group, they put COPD with severe COPD with PH. So it's a little bit still confusing. I think we need to understand a little bit more. But then coming to how we treat in our center would be, firstly, we should be sure if it is just isolated COPD PH, which is very rare to be seen. Only 5% will have mild PH. I mean, most of the patients have mild PH, only 5 to 10% will have that severe PH. So first, coming to optimizing the treatment. Optimizing treatment, we look at our bronchodilators, we increase our bronchodilator, make sure the adherence is good. Then coming to oxygen support, which is very, very important. But then it is reserved for the patient who are pulmonary, who's having type 1 respiratory failure. Then we start because I think that's the only intervention which actually helps in pulmonary hypertension. Then coming to the other things like diuretics, which is again reserved for the patient with fluid overload to decrease the ventricular afterload. Then coming to digitalis or digoxin, we normally don't recommend it until unless patient have left heart failure or arrhythmias with it. Then we start the patient on the other treatment. Now, according to the goal 25, it says if it is you are having a patient with pH and COPD, you can start with single drug. So you either start with, ambrisentan or sildenafil. If it is a severe pH, then you escalate. You combine two drugs, and then you give bosentan and sildenafil or sildenafil and ambrisentan. So in our center, I have only started with one drug with severe, but when I've referred the patient to the cardiologist, he have often started patient on two drug. I have a patient now, and there is one that it's not my patient, it is his patient, but then he's on three drug, triple drug therapy. So we are not personally doing it. I've stopped at one drug, but the cardiologists in our centers have definitely gone to three drugs. That is only reserved for the patient with severe pH until unless you've ruled out everything else and nothing else is working after optimizing your treatment.
I think
again, we have to...
Yeah, I mean, wonderfully said, but any other practices from anybody else in the panel on this particular area? Anybody, any preferences? Somebody chooses macitentan because it has mortality benefit. Somebody chooses tadalafil because it's once in a day. So, I mean, are there any differences of opinions on this?
Sir, although not recommended, I mean, I have not read in the literature, but what I do, if the patient is having on echo, if the patient is having dilated RA and RV, then I would like to add diuretics in such patients if the patient is having associated pulmonary hypertension.
Clear-cut right heart failure, and then you would be definitely using. And have you come across the so-called suicidal right ventricle? I have come across it at least 5-7 times. The moment you put something on and the BP just crashes because there is nothing coming from the right ventricle to the left. So I think, and then you have had it. Just now we are discharging a patient who was 2 weeks on inotropes because we initiated diuretics and pulmonary hypertension therapy because it was a severe bad right ventricular failure and a bad pulmonary hypertension. And the moment I put it on, well, I mean, the whole thing goes into a massive problem. So I think we have to be careful, cautious, and still optimistic because this patient is getting discharged in a much better state after 2 weeks of trouble. But of course, she went into a left ventricular shock first up, and then because she was in the ICU, she got a septic shock also on top of it because it was a secondary infection. So all sort of things go wrong with these patients. So I think more they are in the ICU, more they are likely to prematurely die. So one way or the other. So I think preventing, one way or the other, preventing them from getting into the ICU also matters. But at the same time, I think treating pulmonary arterial hypertension in a small, very, very tiny subset of patients is a priority. It's not a priority for everybody. It's a small subset of patients who have a truly disproportionate pulmonary hypertension. We would like to treat it. And of course, I mean, you have to struggle with it. It's not going to be an easy task. It's not a standard of care recommendation, but at the same time, we will have to do it in some patients. Tilka Madam, I come to you with one of the last questions of this webinar, and I think you talked about two wonderful molecules, Dupi and the PDA4 inhibitor. I can't really spell it because we have not used it in practice. So there is whatever that PDA4
ensifentrine.
So ensifentrine. So are they the game changers? Are they going to change the whole COPD scenario?
Yeah. I think, as I told you, developing a drug for COPD is quite difficult because of the heterogeneity of the disease. We already have a PDE4 inhibitor in the form of roflumilast, and we have worked with that drug. But here you have ensifentrine, which is 300 times more potent than roflumilast. And it is PDE3 and 4 blocker. So it has all the actions what we are asking for. It's a good bronchodilator, it has non-steroidal anti-inflammatory effect, and it has mucociliary escalator also. So I think we cannot ask for more. But practically coming to the bedside of the patient, I think once we start the drugs and we see the response, Then only we can decide on how the drug will be as far as ensifentrine is concerned. And in that group category where you have dyspnea, nothing else, we don't have a choice of ICS. I think we should look forward to some drugs. We should be more than happy if we have one. But dupilumab, I think biologics, all of us have some experience with the asthma guidelines and things like that. But as I told you during my presentation, the dupilumab, they only found 22% reduction. So for a biologic, which will show to be a game changer, I think at least something above 50% we would like to see. So I think we need to have a close watch on what that space is going to develop on and how many more biologics we are going to have. So I think it's reserved now. Only when maybe next year we will talk about this in detail as we practice more and more patients. We institute more and more, and then we can get a feedback on what it is. So far now, we are being very theoretical.
Both are right now not routinely available. Dupilumab is likely to be available.
Not available.
So I think I asked this question to everybody. These are audience questions, and these are two questions, one from Dr. Priya and one from Dr. Shenba. The Priya asks you what are the most effective ways of reducing COPD exacerbations in resource limited areas, number one. And I'm combining this question with another question which is very controversial from Shenba, role of oral corticosteroids in COPD management.
Oral corticosteroids is only for a short course during an exacerbation. The other way, there is no need to give, even ICS we are thinking twice. So in a pure COPD patient, I think you should be skeptical about oral corticosteroids. Unless you have some other, like if it's COPD with ILD or something like that, then I don't think you should really get into oral corticosteroids for a prolonged period of time. Short burst during an exacerbation, taper fast, and gold says 5 days.
Yeah. Are we true to our heart when we say we just don't do oral corticosteroids in COPD? I'm sure some of my patients, one way or the other, are slow taper, very slow taper, and sometimes I'm not definitely going to recommend it for years, but a few months hanging on with it. Of course, generally we'll end up adding a low dose azithromycin along with it, and the prevention of exacerbation gets looked after. And once they are in a stable zone, that oral steroids gets tapered and stopped. But that taper sometimes is slow in my practice, at least.
Sometimes it never happens.
Yeah, I mean we try to, but we are not able to completely get off it. Maybe 1 milligrams of deflazacort or 3 milligrams of deflazacort gets continued one way or the other, and short of having access to dupilumab or the newer drugs.
Steroid sparing.
Yeah, and with a clear-cut eosinophilia, one way or the other, we land up giving it. Let me be very frank that I do it in real life practice. I think many of us are doing it in real life practice, but at the same time, we don't teach it as a standard of care. Definitely agreed.
The only limitation to that is if your patient has frequent pneumonia, then you should be very careful about it. There is nothing else.
Then even in inhaled corticosteroid comes under a scanner. So if it's too frequent pneumonias, then I think obviously even an inhaled corticosteroid is in range. Akhilesh, you probably want to say something?
Limited settings, that questions. First of all, this regarding oral corticosteroids, I usually taper within 5 to 7 days itself with a short burst. I will just taper. I don't usually prolong unless it is really warranted. It can really lead to this other osteoporosis or other this cataract and all other complications. So I don't usually prolong too much. Second, regarding the resource limited settings, whatever with inhaler, according to the proper prescribed dosage, patient has to be taken in resource limited setting optimally, and also the smoking cessation intervention, not only smoking cessation intervention, all other triggers, whether it outdoor or indoor pollutions like biomass fuel, everything has to be maximally avoided. And even though it is not a structured pulmonary rehabilitation, some sort of physical activities should be ensured. This is my take on these questions, sir.
So I think wonderful. I think we have in excess of 1,500 people logged in, and there are more than 22 questions pending. We can't really be doing justice to all of them, but I'll go in the quickest possible way, one-line answers to from one panelist. So I think Rishi will start with you. Why is inhaled corticosteroid therapy not universally recommended for all COPD patients? This is asked by Pranjal.
Sir, because if the blood eosinophil is there, that may result into recurrent exacerbation, and hence the GORD guidelines suggest that in group E patient, only if there is a blood eosinophil count more than 300, then only we should add inhaled corticosteroids. No need to use in group A or B patient.
Okay, correct. Dr. Humera asks, Dr. Arup, can I ask you this question? Why can COPD patients have a normal FEV1 FVC ratio during early stages of the disease and not in the late?
So that is the actually inadequacy of the current definition of COPD. We are diagnosing COPD only after a fixed airflow obstruction and FEV1 FVC ratio of less than 0.7. But the symptoms or the pathological changes can start very early in the disease. So COPD can have a FEV1 FVC ratio of more than 0.7, but not in the current definition.
Impulse or a force oscillometry, I think you're going to pick up more of those patients. I think keep looking for the newer emerging technologies for early diagnosis of obstruction, airway obstruction, because there are better tools available. Gold suggests consider oral corticosteroids in severe non-life-threatening asthma. Should we go with that in clinical practice? I think this is about asthma. So Saili, we'll excuse you for this question and we'll come to the asthma seminar whenever that happens. What are the potential biologics in eosinophilic inflammation in COPD is asked by Dr. Jia, and I think that has been already beautifully answered by Dr. Tilgam, madam. What are the 2025 guidelines recommendations on genetic and molecular factors which are influencing COPD treatment? Dr. Keval Shah has asked this question. Anybody wants to take this on?
Yeah, genetic, I think there is only one thing, alpha-1 antitrypsin and SERPINA1 gene. There is nothing else which is there right now.
So, one practical question I'm asking you, madam, is do you do alpha-1 antitrypsin at least once in a lifetime with COPD patients? I am not practicing it at this point in time, but somebody suggesting this, that it's such a large country, 140 crores. We don't know what kind of biodiversity we have. So I think maybe genetically some people are predisposed to it. And occasionally you stumble upon one patient.
Actually, by right, we are supposed to do it in young COPD patients less than 50 years who have emphysema as a predominant in the lower zone. But we should remember that alpha-1 antitrypsin can be homozygous, heterozygous. You can even have a normal CT scan and still have, they can only have liver disease. There are so many aspects to that. But I think if we start doing more, we will come out with more and we will also be surprised that we have so much of alpha-1 antitrypsin in our country.
Diagnosing so many viruses and so many atypical pneumonias. I think we are going to be surprised if we start looking for things.
Exactly.
Certain number of patients, definitely. Dr. Harsh asked, what are the emerging therapies or technologies which 2025 guidelines anticipate for future COPD treatment? I think this has been addressed by Tilga madam's lecture. Yeah. I think you can just listen to her lecture once again, and that was a beautiful elucidation of all those aspects. What is the role of pulmonary rehabilitation? I think we have touched upon, and I think one last question we are, I think, now more or less left with is pulmonary rehabilitation should be lifelong, but minimum of 4 to 6 is a must for a result. This is more like a comment by Dr. Amit Rath. I think rehab is a ongoing process, isn't it? I mean, if I start giving somebody an upper body exercise and say, do it for 6 weeks and stop forever, that's not going to be realistic. So whatever we are teaching them is for a 4 to 6 weeks period, but they are expected to practice it ongoing, and every follow-up we keep on checking. Radhika, what do you say on this? I mean,
and they stress on tele-rehabilitation also, gold document.
Absolutely. So are we with this thought? And then I think I'm going to wind up the questions because there's an endless list of questions coming up. But let me first of all thank you.
Sir, I'll just add one thing. So they also in gold they also mentioned that if you are
complete, please. Yes. You complete.
Extending the program beyond 12 weeks, there is no additional benefit, but that does not mean that you stop the program and you stop the exercises. It is just they have to be encouraged, but then the program is done for that duration of the period. And then the patient is obviously educated about the exercises and everything.
Yeah. So I'll start with the youngest, which is Radhika. So I can't guess your ages, sorry. So I'm assuming by your looks. 25 I can guess, and Radhika is not 60 plus. So we'll start with you, Radhika. You are concluding.
Sir, I think there's a problem with my signal.
Yeah. Just your concluding remarks, whatever you want to say. Or we will come back to you.
Yeah, thank you so much, sir. Okay, sir.
Okay. We'll come to Rishi. Your last comments.
Sir, I think
Make it short, everybody.
Sir, I think smoking cessation should be advised in each and every patient who's a current smoker. And number two, pulmonary rehabilitation is underutilized in our country. That should be taken care of.
I come to Akhilesh.
Sir, for a proper COPD management, as I told earlier, everything should be taken care, starting from smoking cessation, optimized medications, vaccination, and everything. But there are constraints of resource and cost effectiveness is there, especially in many part of the places. There are access of spirometry issues also there. So we have to take care of consideration all these things. So smoking cessation, not only smoking cessation in Indian context, the biomass fuel exposure is also one of the most important part, and air pollution also is another important thing. So these we have to take care, indoor and outdoor pollution. Pulmonary rehabilitation should be an integral part of COPD management, not at the moderate or severe COPD time. At the diagnosis of COPD itself, we should start pulmonary rehabilitation, and it should be a part of their life.
Dr. Arup, I come to you.
First, let me congratulate you, Dr. Nitin, for such a wonderful moderation. So you have covered everything, and Madam was excellent in her deliberation. So my small comment will be just COPD is not a disease of lungs only; it's a multi-morbidity. So always look for this multi-morbidity during the treatment.
Perfect. Very beautifully said. And Tilga, Madam, your last remarks.
Yeah, I would add to that. I think have a holistic approach and address each multimorbidity. Even osteoporosis should be taken seriously according to osteoporosis guidelines and things like that. Have a holistic approach, treat the patient as a whole, because it's a very, very heterogeneous disease.
Wonderfully said. I am not going to be bigger expert. You want to say something, Akhilesh? Yes, please. No, you are on a mute.
Continue, sir.
Yeah, thank you. So I'm not going to really go beyond this on the COPD management, but let me, as a organizing secretary of NAPCON 2025, you would call me, if you may call it that, because it is happening in 2025 in Pune between 23rd and 26th of January. Very warm welcome to all of you and everybody who's attending this webinar. Please do join us, and let's make that a very, very wonderful academic feast. With that, and with my warmest gratitude to each and every one of the panelists and Tilga Madam for delivering such a wonderful deliberation on COPD Gold 2025 update. I think thank you very much to each and every one of you. Thanks a lot.
Before winding up, sir, congrats to Dr. Nitin Abhyankar, sir. We don't need any introduction of this Abhyankar, sir, who is an organizer for long and past this Vice President of Indian Association of Bronchology, and the next NAPCON 2024 Pune Organizing Secretary. And all the best, sir, for your endeavors. And thank you, sir.
Thanks a lot. Aditi, you can show the NAPCON slide. That will be. Otherwise, we are done.
Yes, sir. Just a minute. So actually, I'll not be able to share that. It's with Saloni. Yeah.
Good night to everybody. And once
Thank you.
again,
Good night. Thank you.
Thank you, sir, and good night.
Thank you, sir. Thank you, all faculty. Thank you.
Thank you.
Thank you to everyone, all the panelists. Thank you.
Thank you. Good night.
From here, I'm ending this meeting. Thank you.
yeah.
Yes, thank you.
Bye-bye.
Bye, sir. Good night.
Bye.
Good night, sir.